as basic as the talk would be that has been given to me, it's equally controversial, I would say. And that's where it comes in when you say guidelines versus practice. That says it all. So I'll take through through a few slides where I hope I can convey the message right by the end of the talk. So if you look at the incidence of urolithiasis, now I'm not going to take numbers here, but then it's all over the world. But we in India are sitting bang in the center of it. And I'm sure many other regions are also having the same incidences. But if I have to look at the agenda of today's talk, I would split into these headings where I'll start with a brief introduction, then I'll take you through the evolution of MET, the literature, and how MET is going to play a role in pediatric age group, in pregnancy, then a brief note on guidelines and the current trends in practice to compare with guidelines. And then I'll conclude with a nutshell in a slide. To introduce, I mean, urolithiasis is something which we see day in and out. It's got a risk factor of, say, around 5 to 10%, and the recurrence rate is quite high, 50%. That is the reason why you keep seeing your patients again and again. And the lifestyle disorders in these days were like obesity, diabetes, and metabolic syndrome kind of diseases are not helping our cause. The incidence is growing by the day. And of course, we have multiple modalities to deal with stone diseases. And one of them is, of course, medical expulsive therapy, which is kind of offshoot these days. And the choice of intervention predominantly depends on the patient, surgeon, anatomy, and the stone characteristics, of course. That holds good for any of these modalities we look at. But as a part of introduction, I would like to make another three statements here. It's by and large, in majority of the articles, you see that if there's no active treatment indicated in these patients, MET is indicated, okay? That's drugs and used and to avoid a surgery. And it's not only a primary therapy, it is also used as an auxiliary therapy after a procedure like ESWL or URSL. And the controversy is all around purely because of the contradictory results from trials and meta-analysis of all the data you could find, both of high quality. And that's where the controversy sets in. But whatever said and done, it's an excellent choice. Why? It decreases the colic events, the narcotic use goes down, the hospital visits come down, the treatment costs go down, and the chances of surgery is slim if MET is effective. Of course, it's an excellent choice. Why wouldn't the patient say no to it? And if I look at the evolution of how it all started, the primary way of giving increased fluid, it could be in terms of oral or even IV fluids in some instances. Antiemetics and analgesics were a supportive form of therapy to this. And then the whole scenario changed. The moment we characterized the adrenergic receptors and the smooth muscle physiology, the more we understood this, the more we got into the expertise level of using our drugs. Then started the targeted medical treatment in terms of antagonists to adrenergic receptors and then blockers of calcium channels. There are a few other drugs which we normally consider in this. To put it in a gist, these are around 6 drugs, if I would like to say, mostly seen in our literature. The first one being the most common and the most effective, as per a few data we go through, is alpha blockers. And to briefly cut short on the physiology part, yeah, that's where it acts on the alpha-1 blockers, thereby the norepinephrine doesn't have an action, and the increased IP3 protracted pathway is cut short, and the contraction is prevented, thereby relaxing the smooth muscle. That's a simple physiology we've been learning. And the calcium channel inhibitors, one step ahead, and they act on the actin-myosin complex, and thereby helping the relaxation of the muscles. And PDE5 inhibitors is another drug of choice which was used or which has been used, wherein the PDE5 inhibits the conversion of cGMP into the GMP, cyclin guanosine monophosphate, and thereby increasing the levels of cGMP and helps in relaxation. And the other drugs, here would be corticosteroids, which has been contemplated and said that the edema is reduced using these and thereby helping the stones to fall off. Mirabegron is another molecule which has been recently considered as a beta-3 adenoreceptor, which helps in MET again. And bromelain is a COX-2 and a PGE2 inhibitor, which is mostly seen in the stem and leaves of pineapple. And it's got anti-inflammatory action and thereby giving it a property good enough to use in MET. And let's go through the literature in brief, which I wouldn't take too much of this as it's controversial in its own way. But yes, the whole story began in around when the literature coming around in 2005, where medical therapy to facilitate urinary stone passage has been a very commonly advocated thing. And there have been enough studies and meta-analysis in various journals from various centers across the world. And yes, it has been well established and told that it is a modality of treatment we are supposed to consider. Alpha antagonists and calcium channel blockers are drugs of choice where you have excellent results. You should go ahead and 65% chances that the stone passes out. And the number needed to treat is around 4. It's around 3.3 for alpha antagonists and approximately 3.8 for calcium channel blockers. That would say around 4. Adverse effects, alpha antagonists were much better off when you compare it to calcium channel blockers. Having said that, there has been equal amount of literature saying about corticosteroids when used along with tamsulosin has got a very good result. Say, for example, if you use tamsulosin alone, it's around 60% according to this paper from Italy. And if you use it in combination with corticosteroids, it shoots up as high as 84.5%. So there comes literature which supports combination therapy of tamsulosin with corticosteroids. Now I've put a small heading here saying contradicting data that comes around 2009s and 10s. All the papers started talking about, is there a role at all for an alpha blocker? Say, for example, tamsulosin in this paper for dysleutic stones of 7 millimeters or less. So what does the paper say? It does not improve the stone expulsion rate. So suddenly you have data which says that whether you give an alpha blocker or not, the chances of a dysleutic stone, which is smaller than 7 millimeters, has got an equal chance of it passing by. But as much as we say this, the drugs, the ideal drug for an MET has started to float around in the literature from tamsulosins to silidosins and doxazosine. There have been various many papers. So let us look at them in brief again. Now, alphazocin for stone expulsive therapy, this paper from Manoj Monga and his colleagues says that yes, it's a brilliant drug. You should go ahead and use it. There is no harm in doing it. But the whole thing, as far as drug choice is concerned, took its own twist with this research paper from the Japanese saying that examination of alpha-1 adrenoreceptor subtypes in human ureter, wherein they picked up alpha-1D, is one of the most densely seen receptors in the ureter next to alpha-1. So obviously now we started shooting drugs which are more selective to alpha-1D, and there comes in naftopidil. And once that comes in, we automatically start to compare it with the alpha-1A, that's your naftopidil along with tamsulosin. And what did the literature at that point of period says? It's naftopidil. The choice goes to naftopidil. It says that this is, if not on the same lines, slightly better than tamsulosin. And then comes another drug of choice, silidosine, is a selective alpha-1 subtype adrenergic receptor blocker used in expulsive therapy for stones. And now you have selective blockers in comparison now. Silidosine provides a better stone passage. And next comes literature which compares naftopidil, which is alpha-1D selective, and this comes to alpha-1A. And it's more or less on the same lines. They say there's no significant differences were noted in stone expulsion rates when you compare these two. So I'll call it a draw. It's a draw now. And like I mentioned, let us see where these alpha blockers have got a role to play in pediatric age group. And this is a paper which comes out from our professor here from Kemel and his associates, and they have compared about how we use in different age groups in pediatric age groups. And if you look at carefully, the stone size, which is less than 5 millimeters, it's bang on. The stones have been passing off. And the expulsion rates, as far as the age criteria is concerned, the younger the child, the more chances of the stones passing out rather than compared to a child who is more than 7 years old. That's an important observation made in this paper. So bottom line, you can use alpha blockers in kids and quite safely. You need to indicate them properly. And as there has been enough literature, this from Egypt, which compares tamsulosin for management of dysleutic stones in children. And it's concluded obviously saying that it's a successful treatment modality. You can safely go ahead and use it. There's another paper which comes out as a review and meta-analysis with a quite sizable number of kids that have been evaluated. And yes, it increases in odds of spontaneous stone passage. That's the conclusion from them. Yes, it can be used. And now we come to pregnancy as such. Another tricky group of individuals where you want to use an alpha blocker. And this is a paper where they've been evaluated more than 207 women, and then a short-term utilization of tamsulosin in second and third trimester of pregnancy is not associated with any maternal or infant outcome. So they say it is relatively safe. But however, the point of interest here is there is no significant adjunct for the rate of stone passage. So it doesn't matter whether you use it or not. The stone passage rate is more or less the same. But if you have to look at some predictors as to what would give you a prediction that this particular individual might pass off a stone, there have been some interesting papers that have come down. One of such papers is from Lee and his associates, who say that longitudinal stone diameter is the parameter which you could look for which can predict whether this stone might pass off or not. This is one interesting paper, and the second one being about a C-reactive protein. It's quite interesting if you have to see this. And they say that the patients where the CRP is more than 21.9 milligrams per liter, they have a low stone expulsion rate. So these are the two predictors based papers that are available. And of course, MET as an auxiliary procedure, it's very well used, especially following SWL and URSL and PCNL in some cases. And of course, this paper again from Syeds et al., I'm quoting it again, has very well been established that renal stones after an ESWL also seem to profit from medical expulsive therapy, which is of course being used with quite a few centers. And yes, alpha blockers to assist in case of post-lithotripsy scenario and tamsulosin being used. There's enough literature. I wouldn't want to take you through all these lines. And yes, bottom line is it has got a role in these things. Now, in short, I'll just see what the guidelines say. One slide per guideline. What does the EAU say? Offer alpha blockers as medical expulsive therapy as one of the treatment options for ureteral stones more than or equal to 5 millimeters. Mark my words, it's more than or equal to 5 millimeters. Means to say less than 5 millimeters, you don't bother using a alpha blocker. That's what your EAU guidelines say for this. And if you come to the American Urological Association and Endourological Society, who's come out with joint guidelines, it says distal ureteric stones less than 10 millimeters. They didn't define what is the smaller ones. It's less than 10 millimeters, go ahead, you can still use a alpha blocker. If you come to the subsections part, in pediatric patients with uncomplicated stones less than 10 millimeters, they say yes, you can go and use it. Offer observation, yes, that's one of the treatment modalities in children. In pregnant patients with ureteral stones, well-controlled symptoms, clinicians should offer observation as a first-line therapy. This is what AUA guidelines and say. Let us come to the NICE guidelines. What do they say? Something on similar lines of AUA. You can consider alpha blockers for adults, children, and young people for distal ureteral stones of less than 10 millimeters again. So it's more or less on the same lines. Alpha blockers could be offered as an adjunctive therapy for adults having SWL for ureteric stones less than 10 millimeters. Again, that's the volume of the stone that you're dealing with in SWL, and add it on with an alpha blocker. And I was asked to compare it with what is it that the practice is happening. That's one of the trickiest part to pick up as to what exactly the practice is all about. But I found a paper which has come out from Cleveland and which actually denotes on the current use of medical expulsive therapy among the endourologists. It's quite interesting. The index patient given to them is a patient presenting with an ureteric calculi less than 10 millimeters, adequately controlled pain, and without fever. And what is it that the urologists have chosen? Look at that, 76% of them, if you have to include the observation part, around 88% of them are fine with using an expulsive therapy. And surprisingly, the urologist whose experience is less than 10 years has got more chance of using an MET. The more seniors they are, I guess the more radical they're turning out to be. But however, and if you ask them as to how aware of literature are they when you question them about the Suspend trial as one of the studies, landmark studies about it, quite a few. It's significantly close to 90% of them are aware of the literature. And the mean length of MET is around 22.9 days. That's the duration of expulsive therapy they're ready to give. And if you go further deep into the paper, you see, now here is what I would like to highlight on the controversial part of it. In spite of the guidelines which we've gone through just now about how distal ureteric stones behave well in MET and the size of the stones, look at this. There are 44% to 60% of the urologists ready to use MET even in proximal and middle stones, ureteric stones. In contrary, according to the AU guidelines, don't bother giving if it is less than 5 milliliters. 75% of us are still willing to give an alpha blocker. So whatever the guidelines say, whatever your literature says, there is a certain pattern, I guess, in the practicing urologists who decide which patients require MET and which patient doesn't require. Now, that's a tricky part to pick up. As much as we say about this, look at the other part of it. 83% of them recommend that they need more research on MET. I guess there's enough literature as it is to confuse us, and they recommend that there is more education at the emergency department level that the MET should be more often used. So this gives you an insight of how well the urologist knows about the literature, but how he puts it into his practice. There's some gap in there. I guess the seniors here in this forum will be able to highlight us later in the discussion part. But if this paper concludes this way, that MET continues to be a preferred initial approach among the endourologists for patients less than 10 millimeters, perfect. While the current AUA practice guidelines are followed by majority of the respondents, it's notable that our survey suggests MET is being used more liberally than the criteria was established. So that says both. So it doesn't matter what your guidelines say, the practitioners are quite liberal in using it. If I have to put this in a nutshell, it's controversial purely because of high quality contradictory data. There's equally high quality of studies which says yes and it says maybe, and a reasonable treatment of choice for a select group of patients. It is definitely is, and the previous data still suggests that significant success is possible with MET. Alpha blockers are better than calcium channel blockers. I guess there is no debate much on that. And MET is definitely as an option as an auxiliary procedure. And there's definitely a bit of a mismatch between guidelines versus practice. I'm sticking my tongue out to say this. And MET still has a role to play in carefully selected patients and counseled well patients. So I hope I have put across the point questioned to me by Dr. Jishin. And yes, thanks for this opportunity, Jishin, again. Thank you.